So Veda, can participants hear us right now?
Yes.
Okay. Thanks, Anne. We will get started shortly. It looks like people are joining.
I'm ready.
Hello, everybody. Looks like we have more than the majority of the people that are going to be joining us today, and we may get a few more, but so that we can stay on schedule as much as possible, we are going to get started. So welcome, everybody. Can I get a quick in the chat box, make sure that everybody can hear me okay? Okay, perfect. Thank you very much. All right. So again, welcome to everybody here today. I'm Lisa Nieti. I'm the VP of Health Center Development here at the Arizona Alliance for Community Health Centers. Also with me today from the Alliance, we have my colleagues Emily Oak our Director of Special Populations and Population Health, and Vida de Jesus Lopez, our Training and Marketing Coordinator. So many, many thanks to both of you for all of the work that you've done to make this happen today. We'll all be monitoring the chat for questions, and anything that you might need, let us know, please, in the chat, and we'll be monitoring for that. So as always, I am so very happy that we have so many familiar names and people that have been at our trainings before, and some brand new members. You are some of the most dedicated and passionate people that I have ever had the pleasure of meeting. You care deeply about your communities, and you are definitely an asset to your organization. A very special welcome to those of you that are new board members and first-time attendees to any of our trainings. You wouldn't be here if you weren't equally passionate about your communities and making sure that everyone has access to the best healthcare. Not to mention that health centers couldn't exist without all of you. So thank you for taking the time to join us today. And thank you very much to your health center leadership for knowing that your participation is important, because the more informed you are, the better board members you will be. And of course, I sincerely thank you for being a valuable member of your health center's board. So I will introduce our speaker in just a minute. I just want to let you know or remind you that we're going to be together for the next about 3.5 hours until about 4 o'clock. We'll be taking a couple breaks during the training so that you can get up and move around and not miss anything. But of course, please feel free to do so at any time if you feel that it's necessary. Our trainer today is Julie Boden Schmidt. Some of you may already know Julie because she used to be the head of training at NAC for many years. She has worked with HRSA on new grantee orientations, specifically around board trainings. She has been, and she is still a reviewer for operational site visits. And she also provides interim CEO staffing to health centers when necessary across the country. So Julie comes to us with a wealth of experience to draw from and the perfect background to connect the mission of the health center program with what we do in practice. So Julie, just so that you know who's in your audience, we have board members from 11 health centers across Arizona. They represent both urban and rural areas. We've got tribal entities and health centers that are funded to serve farm workers and those that experience homelessness. We are also joined by a few CEOs and other staff members from some of our health centers. So thank you for joining us as well. Just a couple of quick housekeeping items. We have muted all attendees just to avoid background noise. You can submit any of your questions through the Q&A or the chat tab. Like I said, we'll be monitoring that. We are also going to be recording this training, and we will share it after the webinar takes place. Lastly, we always hope that you will take the time to complete our post-webinar evaluation, because we so value your feedback, and it is extremely important for us as we go forward and decide on what we're going to do for you next year and throughout the year. So thank you very much for letting me take the time to do that. I will turn this over to Julie. And thank you, Julie, and thank you again to all of our attendees.
So I guess it is good afternoon, your time. Also, good afternoon, my time. I happen to be in Kansas right now and weathered a tornado watch on Friday evening for the first time ever in my life. I'm an interim CEO at one of the health centers here. And like Lisa, first of all, I just admire your commitment, and I so share it. I started in this field over 30 years ago, and it somehow community health centers got into my heart and my soul, and here I am, still working with them, and really happy that I can do that. So I got ready for this afternoon. I brushed my teeth, I used mouthwash, put my mask on, and then said, oh, wait a second, this is all virtual. And that can be a challenge for all of us. So I warn you now, I have a list of your names. So if you're checking your cell phone, or you fell asleep, or are eating a banana split, I might call on you just at that moment. And I actually don't mind the banana split part. It just won't make me hungry if that's what you're doing. So let's go ahead and take a look at the agenda. give you an idea what's up for the next 3+ hours. Okay, next slide. Okay, I'm going to start with telling you what my objectives are for this afternoon. It's first of all to, in some cases, remind you, other cases it might be learn for the first time, the roles and responsibilities of a community health center board. And the agency I'm working with right now just merged with a private practice, for-profit pediatric practice. And I want to reinforce that community health centers are a different animal, and to me, a more special animal, but we need to be aware of what that means. Secondly, we're going to apply those roles and responsibilities to this changing environment today. It seems like each week or month or sometimes day, there's something new that we need to be addressing, and we need to do it within the confines of the rules, regulations, laws, et cetera, but also be very cognizant of we can't continue to do business as usual. And then finally, hopefully we'll have a little bit of fun, even if it's just, taking questions, hearing from you. For those of you who have experienced my on-site board training, I am so sorry that you're not going to get little gifts, but you can get virtual gifts. So first, we're going to cover the history of community health centers, qualities of a successful board, issues facing boards, and that's today's issues, and then responsibilities of the boards in the new world. And you will come across a slide and it will say break. And so you will know we're going to take a 10-minute break, loosen your limbs, do jumping jacks, get some water, whatever you need to do. Next slide. So we're going to come back from the break and again, look at the responsibilities and the new world. Relationship with the CEO, strategic planning, strategic direction, conflict of interest policies, financial oversight. This is the ground that we operate from. But now we have to be very aware that it's in a new environment, a new air, and we'll talk about that. So next slide. More responsibilities, evaluation, compliance, community relations, and we'll be particularly taking a look at what is the role of the board during this time of a pandemic. And how do we help our community respond in a way that can get us back to a new normal? Obviously, the demands are on the board is while you're dealing with all of this and you're being strategic, you also have to be effective and efficient. So we'll talk a little bit about board meetings, committee meetings. Some of you I know have amazing, because I've done either a site review or I worked with you, a process for your board meetings and committee meetings. For some of you, this may be new. Next slide. So Margaret Mead said, never doubt that a small group of committed citizens can change the world. Indeed, it is the only thing that ever has. I have a slightly different version. This says, never doubt that a small group of committed citizens without appropriate planning and structure can truly screw things up. So we're going to live in the world of Margaret Mead and assume that you as a small group of committed citizens within your communities really make and can continue to make such a difference. I think Margaret Mead is talking about community health center boards at their best. And my quote is talking about some of the disasters. I was just thinking if that was a strong word, but I don't think it is too strong. Lacking direction, lacking vision, lack of teamwork, poor communication, and all of that can lead to a health center kind of fumbling. And the board has a role, not only that they operate efficiently and effectively, but that they're evaluating the health center to make sure that those same things are occurring there. So there was Margaret Mead in action, I guess is what you'd say. If we go to the next slide. So, and I forgot to do a tally back there, so I apologize. But can you lift your hand or whatever you need to do if you know who Jack Geiger and Count Gibson were and why they were important? So let's see how many people think they know. Raise your hand. So do we have a count, or are we?
Yep, so we're at about 80% of folks do not know and about 20% do know.
Okay, all right. Well, Jack Geiger and Count Gibson were really the pioneers to establish what we now know as federally qualified community health centers. And actually, you can take out the federally qualified part in the sense that they really helped develop community health centers, and that FQHC designation came later. I've been blessed that I have heard Jack Geiger on several accounts. He just recently passed, Count Gibson passed a while back. They were both physicians, and they were both deeply rooted in the civil rights movement. And in fact, Gibson was the first person outside of the Tuskegee syphilis study who raised ethical objections to that. So as a young man, Jack Geiger, again, they're both physicians, went to South Africa. And what he saw was a community-based delivery of healthcare that worked and that was making a difference in a population that was poor, underserved, and yet they were healthy and becoming healthier. He brought that notion of community-based and kind of a comprehensive approach to healthcare back to his practice in the United States. And he got in trouble because he started writing prescriptions for food. And the medical society said, no, you can't do that. And I loved his quote. He said, "The last time I checked my textbooks, the specific therapy for malnutrition was food." So a man well beyond his times, we now know that that's exactly what we need to be doing with a number of our patients. So they went to the Office of Equal Opportunity, and they received funding in 1965. And so this was at the height of civil rights, the height of funding for equal opportunities. And they got funded for 2 health centers. Jack Geiger worked with one in Boston, and Count Gibson worked in one in Mound Bayou, I always want to call it Mount Bayou, Mississippi. And that was the start of now 13,000, give or take, rural and urban community health centers that are serving over 30 million people. And I remember when I was at NAC starting in 2008, I think that it was about the time we set the strategic goal to serve 30 million. We were at about 10 million, if I recall. We were certainly much lower. And I think some people outside the system said, not possible. But you have always had committed leaders. And I like to believe that's why you're here, and that's why you're getting this training. So fast forward, it is 2020. I had just returned from a 5-month interim CEO in Bethel, Alaska. And if you've ever been to Bethel, you only got there by plane. It has about 30 miles of roads, but they go in a circle, 70% Yupik, which are Eskimos, and built on permafrost with tundra over it. Challenging, very challenging. Glad I did it, but challenging. Came back early January 2020, said, I'm going to take a month and just relax, figure out what I want to do next. And then February came, and then March, and our lives changed. I would guess many of us thought, we can manage this for 3 months. We can manage this for 4 months. Little did we know, a year plus later, we're still trying to manage this. As a result of the pandemic, however, for not the first time, and hopefully not for the last time, but for good reasons, the spotlight was really put on community health centers. And it was put on community health centers for a couple of reasons. And we can go to the next slide. And the next one. The spotlight was put on community health centers because one of the funding that came from the federal government to help community health centers provide care to people, both through testing and more recently through vaccinations. Whenever there is a fair amount of funding coming into any entity, but certainly it seems community health centers. We go from a flashlight to a spotlight in terms of what we're doing. But the other thing that the pandemic did, and you all know this, was it really put the spotlight on the inequities in our healthcare system. And so as we looked at the people who were sickest, most likely to die, or at least have prolonged hospital stay and possibly with sustaining problems to their health, we saw our population, ethnically and racially diverse, non-English speaking or speaking a second, having their first language not be English. We saw them living in rural areas, low income areas, and that was our people. And so it was a perfect role for us to play to try and reach out to that community, because some of them were very distrustful of the private for-profit community. Going again back to the whole Tuskegee syphilis study, they had received vaccinations in the past and told it was quite something else. So distrust was high among some populations, access was difficult, and we were now scrambling. I think what's important to remember is in the midst of all of this, we still have the model and of community health centers, and boards are the foundation of that model. And in fact, when there has been efforts to broaden who gets funding for community health centers, I haven't heard of it recently, but it may be in the States, for-profit practice has said, well, look at that money, we can get that. And fortunately, there was a strong commitment to keep the requirement about boards. So let's take a look at the next slide. That's not the one I expected to come up. So let me check my slides, see if we're on track. Yes, I am. So can you go back one slide? I'm sorry. So hopefully you all know this, 51% of your board members must be, and there's all sorts of labeling, but active users, consumers, patients of a community health center. And what this means is that they use the community health center as their source of primary medical and or dental care or behavioral health care or other things that we provide. But those are the three basics: medical, dental, and behavioral health. And that they actually use the services. There were times, I should say, when health centers that weren't doing so well in sustaining that model of 51% being people who use the services of the community health center would have their board come in for flu shots once a year, and voila, wow, you had 100% of your board using the services. That is, of course, is not the intent. And the board must, and the phrase is reasonably represent the patient population. That does not mean quotas, okay? So for example, if 39% of your patient population is African-American, you do not need to have absolutely, in fact, you couldn't, it'd have to be some other number, 39% of your board be African-American, but it must reasonably represent that. I'll give you an example of not doing that. I was doing an operational site visit. I would say it's one of the few times I ever found a health center out of compliance. Their population of people, of Hispanics, was 70+%, okay? That's who they targeted, that's who they primarily served. They had a board of about 15 members, and one person was Hispanic. That is not representative, okay? So and we're going to talk later about with these new demands, what else do you need to look for on the board? But that's an example of stretching the represent part. Non-consumer board members should also be representative of the community. Again, not as strict, but reflecting what the community looks like, and at the same time, bringing in assets, knowledge, experience in areas that the community health center might benefit. So you will frequently see on a board somebody in health, one or two people in healthcare. I think the rule is, however, that no more than 50% of your board can gain 10%. This is your non-consumers, 10% of their income from health. So again, some limitations on that so that you're not weighted down by all doctors or your non-consumer members. So you'll see law, accounting, healthcare. I've seen people who do strategic planning, marketing, and part of what you want to do is take a look at what you need, and that kind of helps guide you on how you recruit for board members in general, and of course, board members who are not consumers. We're going to be going over some of the specific responsibilities, but one of the requirements of board members, it is not a formal requirement, but I think you really absolutely must look at this, is they must be nimble. And by that, I mean, you as a board need to be able to always, along with your CEO and other leadership staff that so designated, be always anticipating what's coming down the road, what next. Now, could we have anticipated the pandemic? No, but once we knew it was on our doorstep, the best health centers quickly had a plan in action. They were nimble, they shifted resources, they shifted staff, and they were off and running. So it's critical to know that the board not only has a strategic plan, but acts strategically in the moment, which does not mean being buffeted by every crisis that might happen within the community or every funding source that might come available. You still not need to keep your eye on your mission and your vision and what you are doing. But again, the word is nimble. Be ready to address the environment and be able to shift as you need to address those critical problems. So next slide. Qualities of the successful. Well, that's interesting. Do they come up one at a time? Because mine have all of them listed on the slide. Yes, thank you. So we'll take it one at a time. So roles and responsibilities are clear. And I think it is really important that there is clarity within the board and between the board and the CEO and between the board and other staff, okay? And one of the things I talk a lot about, particularly if I'm coming in where there's been some problems, is you each need to stay in your own lane. Now, when there is a significant transition, sadly, I'm often called in when the CEO has been removed from his or her position. A board will naturally start to shift a little bit into operations. It's understandable. Sometimes it's necessary. But once you get that ship righted, things are going to get back in your lane. You're there for policy, oversight, community voice, but you're not there to manage the operations. Or I recently had a staff come to me and say, well, we want to spend this much on t-shirts. I guess that's a board decision. Like, no, that's not. So let's be clear. Secondly, make sure roles and responsibilities are met. And what that means, for example, is the chair or president of the board, however you define it, I presume you define it as a chair, has a key leadership role on your board. And they need to play that, which means they help manage the board. So they are responsible for making sure that the board as a whole is effective and efficient, that everybody's voices are heard, that if there is a problem, it's addressed. It is not the CEO roles to discipline or correct a board member. Okay, we already talked about being strategic and nimble. Have effective board meetings. I was working with somebody one time and they were talking about boy, after about 4 hours, we get really tired. I thought, oh, I would be beyond tired after 4 hours. There may be exceptions, but they should be rare. Ideally, I think the work is done in a reasonable period of time, and that is probably 2 hours or less. Now, I've also seen boards that take pride that they're out in 45 minutes. And I would argue that I'm not sure the board as a whole is having the level of discussions they need to be making good decisions. So it's a balance. But I would say if you're in that 4 hour, rethink it. I just saw the board packet, first board packet of this entity I'm working with now was 140 pages. It was like, do you really think they're going to read that? So one of the ways you get members to look forward to the meeting and feel energized afterwards is don't overload them with information, but give them enough information, and keep it under 2 hours if you can, unless, you know, a major problem is occurring. Okay, next slide. So today's issues, the pandemic. I just read Emily Oak's comment that 4 hours is the perfect amount of time for this training. Absolutely, couldn't do it in 2 hours. So today's issues. The pandemic arrived, and I think it's useful to sometimes just kind of remember the time frame. So January 2020, the World Health Organization declared a public health emergency. On March 11th, they declared it a pandemic. On March 13th, a national emergency was declared. And as I said before, probably until that moment of March 13th, many of us weren't quite sure what that meant. Not sure how we were going to respond, nor how our lives were going to change so dramatically. And I can remember we have a place in Arizona. In the winter, we live in Peoria, and driving down one of the main streets and looking into the neighborhoods. And what struck me was cars everywhere because nobody was at work, and children nowhere to be seen because they were being kept inside. So at that point, I'm curious as to what your board did. And this is going to be a yes or no. Do you think at that point, was there effective communication that allowed you to kind of say, okay, this is one of our priorities? So in that moment, was the pandemic placed as a high priority on your list of things you're paying attention to? And was there good communication about it?
Sorry, Julie, we actually have a different poll up right now for the order, which is which of the topics there has the health center placed a high priority on?
Okay, so let me go forward and we'll keep that up there. So the second area is there's always been inequity in this country. We know that. There are, I think, initially when issues of equity were talked about, we often talked about color, race, ethnicity. We began to appreciate that inequity was also related to class, education, gender and gender identity, sexual orientation. The list has really gotten longer rather than shorter. And I think, and this is my perspective, so it may not be yours, but I think the death of George Floyd woke up many people who had not been awakened. I would guess we were already quite awake. We were either experiencing it ourselves, or we were experiencing it within our community, or we were experiencing inequity within our health center even, and trying to deal with that. So, you know, he died on May 25th. not that long ago, 2020, just about a year ago. During the period of January 1 to August 31, 164 Black men and women were killed by police. And I think his death began to highlight that issue. And then as we saw people responding to the pandemic, often thanks to leaders who listed it as, the China virus, et cetera, we're seeing either an increase of violence against people of Asian descent or more visible violence. It's been there. And it's interesting, just as an aside, my youngest son is Korean American, and he lives in Queens, New York. And we just, for the first time, really had this fascinating discussion about what is it like for him and what has he experienced. And honestly, for so long, he was just my kid, my son. And I wasn't even thinking, I wonder what this means for him. Fascinating discussion with him. And then, as we talked about, we know that people who fell into those categories more likely to end up in the hospital, more likely to die, more likely to be in the hospital for a longer period of time, not receive timely and adequate health care, did not have access to vaccines, all those kinds of issues. Really, the pandemic brought it on. So then there's that issue, kind of maybe the second part of equity and inequity, which is inclusiveness and diversity. So the question really for health centers and people within health centers is not only, are we addressing the issue of equity? Remember, we were born in the civil rights, and hopefully that remains part of our roots, that it is what distinguishes us from other healthcare practices in many cases, not in all, but in many private for-profit. That was not their roots. They have a different motivation, good, bad, or indifferent. It is different, and our roots are quite different. But now we really have to look at inclusiveness. And to me, that's when you have an environment of letting people in and making them feel welcome. And that who we're welcoming in is a diverse group. So it's one thing to say, we need to have equity. It's another thing to practice it. And the practice is the inclusiveness and the diversity within your board and obviously within your staff. And having them feel welcome. I think that is real critical. This health center serves a fairly large transgender population. As a result, they very deliberately have a person who is transgender on the board. And one of the things I know they struggled with was he going to be welcomed? He was. But if not, don't keep him or her off the board. Work with your board on that. Sexual orientation, probably, given everything else, in most states, most communities, isn't as big a deal as it used to be. But you might not want to travel to certain parts of the country and be openly gay. That still happens. I think we all know as women, there's still gender issues. And that may be true for men in traditionally female roles. So I have had friends, my nephew being one, who's a nurse, and people just have trouble dealing with him as a male nurse, although that's becoming more common. Let's do the social determinants of health. I want to go back. Sexual orientation and gender, not a new issue for the most part being dealt with, but I do think a lot more visible. With most states and then the federal government weighing in on marriage of people of the same gender, there was a shift, and particularly I think among most of our younger people. And then, and Emily, do we have the question about your level of comfort the board's level of comfort. Yeah, great. And we'll go back to that last one once we finish here. But I'm interested in how comfortable you think your board is in talking about gender identity in terms of patient care. I noticed that the Alliance staff is great about including what pronouns apply to that in particular individual who you're writing to. We have had situations where at the front desk, we have a person who's transgendered and they wish to be referred to as he and called Jack, and Jack's mother is right there and insists on calling him Jody. So we know those issues come up, and the question is, how is your health center dealing with this? How are you dealing in talking about it, your comfort level? So please vote, not comfortable at all, somewhat comfortable, or very comfortable. So you all should be able to see that 46% said they're very comfortable. Some, about an equal number said, well, actually an equal number said somewhat comfortable, and about 7% said not comfortable at all. One of the discussions you might want to have in your board, I would highly recommend it, is ask people, and this is risky, so you may choose to do it through a written process versus an oral process. But to really find out what's going on, it helps to find out what would it take to move them up one level. So if they are not comfortable, what is it going to take to move them up to somewhat comfortable? And if they're somewhat comfortable, what is it going to take to move them up to very comfortable? And I think if you ask that question, you will really get to the heart of some of the discomfort, for lack of a better word, that people feel about this issue. And it will help you better frame as a board how you might approach that, whether that is through training, whether it is through discussion within the board, whether it is discussion with people who may not be on the board, but represent a variety of that kind of diversity. I really understand it can be confusing and hard to address. My spouse is a teacher and has a student who identifies as male, was born female. So identifies as male, wishes to be called a male name and male pronouns, but has really gone into wearing pink, pink bow, pink dress, pink hat, pink backpack. And Vic said, I'm just kind of confused about the message. And I didn't have an answer, but I knew somebody who did, and talked that out. So sometimes it's useful to talk to people who are either in that position, or in this case, for example, here in Kansas, there is a physician who's done incredible work in this area. He himself is not transgendered, but recognized as somebody who is so sympathetic and passionate about this issue and having people feel included. So let me talk about the social determinants of health, and then Emily, if we can go backwards and get to that other poll. Think back to Dr. Geiger's prescriptions for malnutrition, which was food. So social determinants of health, and it has become, that phrase is actually kind of a standard phrase now, that really addresses the conditions in the environment into which people are born that are going to affect their health. And we've talked about maybe the most visible, their race, their ethnicity, their gender. But where people are born, live, learn, play, worship, where they and how they age can affect a wide variety of health issues. and health functioning, and also not health functioning, but really the quality of life. And so health centers have played a key role in identifying those social determinants of health and how it affects the people we serve. Even to the point where, and I don't know how many states have done this, I'm afraid it's probably limited. But for example, Oregon was one state that the Primary Care Association was really working with the Medicaid, with the private insurers rather, so that social determinants of health added, if you will, a plus to the reimbursement. We did a study when I was in Seattle that showed that if interpretation was required, the visit was 25% longer, and which meant productivity was about 25% shorter if you were serving a large number of people who needed assistance in speaking English, and or through their own language, but through an interpreter. And so there's some work, but I'm not sure it's as widespread as we would like. So think about that, is when you're getting paid by a private provider, is there a recognition that it is more expensive, but more effective to deliver care to some of those populations if you address the social determinants? Medicaid, in a way, already does that by doing, in most cases, some kind of enhanced reimbursement, which is really hopefully speaking to, we know you have a more demanding population, you need to provide more services, and we're going to partially pay for that. So, Emily, let's go back and see that slide where people got choices of these 5 areas of issues.
Hold on just a second. We're seeing, oh, there we go.
Okay. All right. So that is great. But what I think that says to me is, so pandemic, high priority, 100%. I wouldn't expect otherwise. Equity, 44%, inclusiveness, diversity, 31%. This is very interesting. Sexual orientation, gender identity, 0. 56% social determinants of health, and none of these yet. We know the pandemic was a crisis, a major crisis, and you couldn't ignore it. It was in your community. People's lives were at risk, including your lives, your family's lives, etc. And so there was a very natural reaction to shift your focus and say, we need to deal with this. And I had a staff person just the other day say to me, that was such hard work, because we immediately went into action. We set up a outdoor screening where people came in by their cars. We staffed it for many hours a day. We worked on Christmas Eve, and I have never felt higher staff morale. So we did great. I would argue that in some of the other areas, you still need work, because these are issues that are rooted in why community health centers came about, particularly the equity, inclusiveness, social determinants of health, and honestly, sexual orientation and gender identity is a partially social determinant of health. I mean, it's also biologic. So you might take a look at this. I would suggest you go back to your own boards and perhaps take that poll and see how your individual health center does. And that may help you as you plan training for your next year with your board. So we're going to close that one. And we're going to go to the next slide. So what do these words mean to you? Hopefully the words are going to come up. And never mind that last slide. I think I got it out of order. So responsibilities in what I'm going to call the new world, our current world. You as a board must develop and amend the bylaws according to the mission statement. That is your responsibility. And one of the things I think your board needs to look at is, has your mission, value, vision, and value statement been impacted by the challenges of today? When was the last time you looked at your bylaws? And do they reflect what you're still doing? And do they, let me give you two examples about, do they reflect what you're still doing? So in Seattle, the health center that I ran there was, with one exception, there were 6 clinics, 6 health centers, clinics in housing projects, and one was outside of the housing project. Those housing projects had started in the 30s, and it was really for the Eastern European migration of people. So many people of Jewish faith, Jewish background. And then over the years, starting in about the 40s, it became a more African-American population that was staying in the housing projects. And when the health center was developed, that was still the case. And so there was some mention about meeting the needs of the African-American community. And then we didn't look at that mission. It hadn't been looked at for a while. And when I came on, I looked at it. Well, in the meantime, who was in the housing projects was changing, and it was becoming a Southeast Asian. So we saw fewer African Americans, but we saw a growing number of Lao and Hmong and Cambodian, and we really were stuck in the old mission. Later, it shifted again, and it became Eastern European. So we really need to look at, here's our mission, but you know what? Our population has changed. And do we want to broaden our mission so we recognize who we're committed to serving? I was working with a health center. I honestly do not remember where it was, but they felt very strongly about serving their community, and they defined their community. And then one day they looked around and went, our community got gentrified. And so there was this community health center in a neighborhood of fairly affluent people and affluent homes. And so they really had to look at their mission and vision and say, should we stay here or do we need to move and still meet the mission that we originally set? And they chose to move. Another example of making sure your bylaws are what you practice. Remember, the bylaws are what govern the board. So I was asked to go to Wisconsin to visit a health center. I was asked by the project officer, and there were several issues. And one was that their bylaws said that they had term limits, and the term limits were pretty standard, 3 years, 2 consecutive terms of 3 years each, and then you had to be off for a year rather. So I went up there, and I admit I acted a little ill-informed, and I said, so introduce yourself. This is to the board, because it was board training. Tell me what your position is on the board, if you hold a committee chair or you're an officer, and tell me how long you've been on the board consecutively, how many years. And people were so proud to say 21 years, 18 years. I'm like, well, that's very interesting. Do you know your bylaws say that there's term limits? So again, those are, if you will, the laws that govern the board. Don't have it in there if you're not going to follow it. Do have it in there to represent the current. And by the way, don't put anything in there that is illegal. So I got sent out again by a project officer to a health center to do board training. This was not in your state. And in their bylaws had been that they would pay a stipend to every board member of $100 for every meeting they attended within the course of a month, including committee meetings. Not surprising, there was 100% attendance at board meetings, and every board member was on at least 2 committees and always showed up. That is against the law. In the statute, it says you can't do that, with one very rare exception, which has to do being extremely low income and et cetera. So they had been told that, so they took it out and made it a policy that wasn't in the bylaws. And then I came along and they took it out of the policy, and they just basically said, well, we'll do it under the table. Just so you know the consequences of a board acting that way, there is an Office of Fiscal Integrity, I think that is its title, and you do not want to have to report to that office because then you're in trouble. And they had to send years and years of financial statements and audits to that federal office. So be sure you're reviewing your bylaws. Make sure it's consistent with what you are doing today and also what you want to do, where you're going in your vision. Make sure that there's nothing in there that you're not doing, but you say you should, and don't have anything in there that is illegal. So your mission should reflect who you're currently serving, what you provide, and how you provide those services. Do you have a value statement? Value statements aren't usually in bylaws. Some boards adopt them. Many times that is a staff effort, but I recently worked with a board that actually adopted value statements. And it was a very interesting process for them to ask themselves, what do we value the most? And then you take a look when there's reached some level of consensus about that, does that reflect our mission and vision? So it's all kind of circular. Now I'm going to go back to the new world. Your value statement and your vision. You need to ask yourself, does it address the issue of equity and inequities? Does it address the issues of inclusion and diversity? And you may want to consider a board culture statement. And I found one that I liked. Example, the health center commits to, the board understands its fiduciary role and is committed to ensuring the health center fulfills its mission and remains sustainable. The board is committed to navigating crises in partnership with the CEO. The board understands its role to govern. It is respectful of the CEO's role, committed to openly discussing times when roles may be blurred or micromanagement occurs. I don't know if we have a poll on that one, Emily, but you might ask yourself, do you ever get into micromanagement? So let me give you an example of the difference. I always say that the amount of information that should only come to the board is like a funnel. And at the top of the funnel, it's its widest, and that's what comes to senior management, to, it's a lot of information, okay? Senior management, we're going to say about weeds that down to a little bit narrower funnel, and that's what goes to the finance committee. And they look at that, and then they bring down enough so that the board as a whole can understand their financial status, understand where there might be challenges, and can make informed decisions. But the board should not deal with the 140 pages of information, of which 85 is financial. They're going to get lost. And so, that's just me talking about, don't get into the micromanagement. Important.
One question, just if you can, if you'd be willing to share that full statement with the attendees, they really liked it.
I will definitely do that. I presume Emily will do that afterwards, and I'll also at that time share with you the reduced financial assessment.
Yes.
Does that work?
Yep, perfect.
Okay, great. This is another important part of that statement. The board's composition reflects the diversity of our community and includes members with various expertise and community connections. We value the contributions of all members and are inclusive in our approach. And so the question is, and Emily, do we have a question on this one, which is, we didn't, it comes later, but are the 51% of your consumers really consider your health center as their primary source of care? And is there value as a community member, as a a user of services really used. One of the best things I saw when I learned so much going out on operational site visits. And one health center, might have even been in Arizona, listed on every board agenda, discussion with, this wasn't the exact wording, but basically a time for consumer board members to share what they had experienced, what they were hearing in the community, etc. And that is so critical because that's why you have them on the board. I'll give you an example of how it can make such a difference. I was working with a health center on strategic planning in Ohio, and one of the board members said, we were talking about what are the needs out there in the community, and a board member said, I'm very concerned about our infant morbidity and mortality and our maternal morbidity and mortality in this community. And there was, at that time, the position was a director of nursing, and she oversaw that program. Her face turned bright red. She leaped up off her chair, extremely defensive. What are you talking about? I took a time out. Everybody regained their breath. And then what we learned was she was like, we have great statistics. Yes, she had great statistics for people who made it into the program. He was talking about the community as a whole, which included a number of people who were not in that really high quality program. And that's why you have board members who live in the community, participate in the community, and speak for the community. Okay, let's go on to the next slide. Oh, look at that. The clown means you get to get up and move in a moment. So I'm gonna take a look at my notes. The duties of care, loyalty, and obedience has another word. And I admit that when I started in this field, I was not well versed in that area. But care, loyalty, and obedience are formal legal terms that are part of the fiduciary responsibility of a board. And fiduciary does not just mean financial. Obedience, we're going to work backwards, means that if the board makes a decision, you will support that decision. The time for not supporting it is within the meeting. But once a decision has been reached, there's an expectation that you will go out and support that decision. And you may very well ask, can we review this in 3 months, 6 months, to make sure we made a good decision? Loyalty is to the mission, to the health center, to the reason for existing, and to support the health center. I had a board member, he came out of the housing project, so he was low income, and he questioned why we had a sliding fee scale. We should all make people pay. And he wouldn't get away from that statement. First of all, I was totally befuddled because he was low income and he would experience problems possibly. But also, he needed to understand that that's what we were all about, and he needed to be loyal to our mission and our cause. And care is that you're going to provide the kind of attention that a competent, caring, committed individual should do, which means you come to the meetings. You stay awake during the meetings. You involve yourself in discussion. You read the materials before it happens. So those are some of the kind of the basics that you need to have. But as we talked about, there are all those other issues that you need. And you really need to make sure as you orient new members, and by the way, selection of board recruitment, selection, orientation, training of board members is first and foremost the responsibility of the board. Now, you will do it with your CEO's help, and she may or he may pass that off to other staff who can assist. But ultimately, it is your responsibility to make sure that you get good members on that board who are going to add value. I personally like term limits, and I'll tell you why, but it is not required under FQHC or the Community Health Center rules and regulations. It brings fresh perspective to the board, which is often needed. It can address some of the new concerns, and you can then seek people. All of a sudden, you need to do a big marketing campaign. You don't have somebody skilled with that. Well, maybe if you got a board member with that, they could at least guide you, not do it, but guide you in that area. And the other thing is that when you get entrenched, you potentially have problems. Remember the example of we paid everybody $100 for their attendance. And in fact, one board member actually said to me, but I just got a new apartment and I need at least $300 a month. And I reminded her what the mission was at community health centers, which was not to fill the pockets of the board members. So, you need to be clear about that. What had happened in that board is the same 4 people had controlled the officers for years and years and years. And try as they would, it was hard to break that. And the only way they were going to change that culture was to get new board members in. I called them the nest of vipers, which was probably not very correct or nice, but that's what they were. They cooked up deals for themselves. And it was certainly not to the benefit of the health center or the patients served by that health center or the community. So make sure as you're orienting new members that you're considering all those things we talked about, but also that they understand these are the obligations if you're going to come on this board. And if you're not comfortable with that, that's okay. There's probably other opportunities for you. So let's take 10 minutes. That, according to my watch, would get us back at 1:45 time. Does that work?
Yep, 2, quarter till 2. Well, yeah, quarter till 2.
1:45. So everybody get up and move around. Back here on the dot at 1:45. So Emily, I have that it's about 1:15.
All right, sounds good. So we'll go ahead and the poll's up for folks that are back to let us know if your health center is in an urban or rural location, or maybe you have health sites in both.
Okay, a great mix. And for those of you in, actually, I've heard urban health centers say, you don't understand the complexities of urban health centers, and I've had rural health centers say, you don't understand the complexities of rural health centers. And the truth is, we're all in this together, but there are differences. And I ran a rural health center in New York, having run an urban health center in Seattle. And the feds came out and they were really into diversity. And my board president was this very frank speaking farmer in central New York with a lot of dairy farms in our area. And when they raised that question, he said, we have diversity. We have the haves and the have-nots. And although that was rather blunt, it was an example of that particular rural area. It was very white, but there was, in some ways, terrible diversity regarding income and access to healthcare and education. I can remember I'd been there 2 weeks and I asked one of my staff, what is this with all the people missing teeth? I see them on the streets. And I happened to be in a group with the Episcopalian priest at the time, and he said, we refer to it as the Cortland smile. And it was that culturally in that rural area, people expected, especially low-income people, that by the time they were 30, they'd have dentures. So again, differences, but hopefully appreciated from both sides. Did we have a question about how long they'd been on the board, Emily?
Vida, might be, you'd be able to look at that. I believe that. Oh, there you go. Thank you so much.
So if you could let us know if you've been on less than 1 year, 1 to 2 years, or more than 2 years. Wow, look at that. I'm impressed. Although you might ask yourself, are we getting enough turnover? But, with what, less than 40% having been less than 2 years, that's good. You've got a solid base. And, maybe a little more balance would be great, but obviously it's working for you. So remember I said I might. So Wendy Armendariz, are you on? You can just chat and say yes or no. What about Laura Mendoza?
Hi, Julie. This is Wendy,
Hi, Wendy.
also known as Maria.
I'll tell you the story there. So I worked with Wendy several times, and she looked just like my friend Maria. So I kept calling her Maria. I finally said, I will pay $5 to your donation collections for every time I call Wendy Maria. They got $20 out of me before I finally stopped doing that. Now I'm working with a Dr. Goodyear, but I kept calling him Good Night. No, his name is Good Night, and I kept calling him Dr. Goodyear, and his name is Waco. So the other day I said to him, someday I'm going to call you Wacko Goodyear. And he just said, yeah, I know. So glad to hear from you, Wendy. Is Laura Mendoza on?
She is. She responded in the chat.
Great. So I know the two of you are on. I may go back and find out who else is here. Wish I could see you. We were having a problem with bandwidth. And I think what happened is I'm living right now in an extended stay part of a hotel, which is like a studio. Off to my left is the bed. In front of me is the kitchen. Behind me is the TV. It's very compact, but it's a very old historical building. And I just don't think it's wired to the point that we could get all your pictures up. And I'm really sorry about that, because that would have been great. All right, so let's move to the next slide. So responsibilities in, hang on, seems like we skipped one. Yes. Can we go back one slide? I might have just missed it. Yeah. Is that back one slide? Or forward?
It is forward one slide.
Okay, so can you go back? Now go back two. Okay, but let me, obviously I did put it down in there. So, in this world, we are now facing challenges as boards that we didn't face before. And obviously, one of them is that it's virtual. So we went, I think a number of rural health centers do some virtual meetings anyway. We did in New York because, we'd get 100 inches of snow each winter. People in our outlying, even more rural centers just couldn't get in. But it tended to be more, we did a conference call, not anything very exotic. We have to socially distance. I think, I know our board is not yet back to meeting in person. Our whole board is now vaccinated, which is great. And of course, working in a health center, all but 2 people are vaccinated at this point. So that has added a challenge. We also know that we're dealing with all those differences we talked about before. And so I think the healthcare model is even more critical perhaps than it was 20 years ago. And I use 20 years ago because that was kind of the point in the 90s where it became, oh, you have to run like a business and we need to get, business people on here. And that's the approach we need to take, which is true. But being a patient majority, being diverse, being community-based is always what's going to hold us together and see us through the ups and downs of both the environment, the funding, and honestly, how Congress looks upon us. That's what keeps us there. So things to consider, again, when you're looking at your board, define the expectations, review job descriptions. So obviously that begs the first question, which is, do you have job descriptions for your board? I think it's really important to have expectations and job descriptions. Expectations, you're expected to attend every board meeting unless, there's a significant reason not to. So many boards have in their bylaws, you may only miss X number of board meetings that are not approved, and then you must be removed from the board. I have yet to find a board that did that. They know people showing up once every 3 or 4 months, don't seem to have a good reason, don't request it, in advance, but they keep them on. And that goes back to what is that role of the officers? It is not the CEO to be the one talking to those board members, should be the CEO making sure that the board chair and others of that executive committee know about the attendance problems. But again, don't have it in your bylaws if you're not going to practice it. And then if you don't have that in your bylaws, you have to ask yourself, why would we do that? There are times when you really want somebody on your board, but they have a very busy schedule. They're philanthropic and pulled on by everyone. Oh, look at that. Somebody did. Yay. From Anna Newland. They did remove somebody. Good for you. And I'm saying good for you and probably lost my little train of thought here. Anyway, it will come back. So make sure the expectations are clear, attending meetings, reading the information, have a job description, and both for officers and others. It's going to be pretty simple, but you want them to know what they're walking into. Do a gap analysis. Take a look at, separate yourself from who's currently on the board and ask yourself, what kind of skills, experience, etc. do we need? And then take a look to see if you have that. And if you don't, and it's pretty critical, hopefully you have some mechanism by which members go off and you can now bring that expertise or skill or experience. And that may also lie, important to remember this, with your consumer members. one of those consumer members may be an incredible communicator and can help that board get out when they're stuck. So look at your board as an entirety and figure out what do you want, what do you need to have, and what do you want to have, because both. I think one of the questions we have to ask ourselves is how can we better, or how can we actually adopt our recruitment process to better address the challenges of recruitment in a virtual setting. So what I often do is I work with a board chair, potential members are identified, you set up a time, you have them fill out some forms, you get their background before you even decide to pursue, one-on-one with them. And then we would meet them. And I would talk from a staff perspective, the board chair talk from a board perspective. I would usually kind of give the history of the health center and what we do and the services. Board chair would talk about the requirements of being on the board, what the board is like, et cetera. And then there was a discussion about, does this feel like a good fit for you? Obviously, offline, is this a good fit for us? And you move forward. Well, now you have to find people virtually. And then you have to do all that meet and greet and consider through some kind of virtual experience. So you can still rely oftentimes on your board members, staff, and particularly your providers are really good, I think, at selecting or suggesting a potential patient who could be a good board member, as long as that provider understands what it means. Because you don't want to get somebody who's just really, off in left field, but the provider really likes that person. You have to ask yourself, do all the people that we would like to be, or the kinds of people and the specific people that we would like to be considered, do they have access to the kind of equipment we're going to need over the next X period of time to be able to be involved? And I'm sure in your communities, in many of your communities, in our community, I live on an island in Washington State, and sadly, a fair number of our kids did not have internet service, and some didn't even have computers. And thank heavens again for a small community. The community rallied around the internet service, local rallied around, and every child got a computer and got internet connection. But that may not be happening in your community. And so then you need to think about, how do I address that? And I would say it doesn't automatically rule somebody out. You might ask, do you have a family member that you're comfortable visiting with that has that access, that you could get access to it through them? So don't give up, but it requires you be very thoughtful right now about how you do that. So the other thing you should look at as you're recruiting is what practices might we want to adopt? What practices should we improve to have that diversity and inclusiveness and better engage and retain members? Now, given the poll, it looks like you're doing a great job of retaining, and that usually tells me that they're engaged. If they're sitting there and just don't understand why they're there, don't feel a value, have 101 things that are in their head that they're going to, they're not going to be on that board for 2 years and more. So as a group, you're to be commended because you're obviously working on that. So I think we have a poll coming up. 1 equals harder, 2 equals easier. And that has been virtual, made it harder or easier to connect and make critical decisions. 1 is harder, 2 is easier, 3 is not sure, or about the same, no change. And by the way, I don't assume the answer. Let's see what you say. Okay, this is when I wish we could see you, and it's the one challenge of virtual. With a third of you saying it's easier, I can only guess at why that might be. I do think that some people get very nervous in groups. I would also guess that if it's easier, that you have developed a mechanism, and if this isn't the case, you might want to consider it a mechanism by which people are heard. So that may mean the chair will say, I'd like to hear from each person now, and names them so they have an opportunity to speak. So that's just, one example of they're not intimidated, if you will, by the group. If they're shy, they may not be as shy on the phone. On the other hand, if they're really used to and like that camaraderie and that connection, it can be more difficult. So just something, again, to be aware of as you move forward, and who knows how long we're going to be in this state. It's going to vary by where you are. So let's go to the next slide, which is selects, evaluates, and dismisses as appropriate the CEO. So interim CEOs are often called in because somebody selected, evaluated, and then dismissed the CEO. So the first question is, what qualities should be considered, and how did that differ from 30 years ago? So if you think back about, I'm going to go more than 30 years, in the 80s, when health center boards were looking for, often they were called an executive director at the time, many were looking for somebody who was very community-based, who was a community organizer, who was good at going after all sorts of funding, and maybe not a high priority was being businesslike, having any experience with business. So, they got people out of the civil rights movement, out of other movements, out of people who were community organizing, and that's who they got there as CEO. And it really helped build up the feeling within that health center with the board that we're doing the right thing. We've got a great mission. Then in the 90s, mandatory managed care reared its head. And all of a sudden it was like, whoa, we really need to be effective and we need to be efficient. We need to approach this like a business. So what I saw was in the 90s, more MBAs being hired, people coming out with that business practice, less emphasis on the community organizing. Question, I'm not sure there was less emphasis on fundraising, but maybe a different kind of fundraising. And what some, I'm not going to say all or many, but a number of health centers discovered was, boy, this person really knows business. They can tell us what our margin is at any day when we ask and what we have to do. But they don't seem too committed to the population we're serving and our mission. They almost sometimes seem more interested in building an empire than making sure we're meeting the needs of a community, which doesn't mean not growing, but why are you growing? And so I saw a swing again where the two were combined. Okay, you want people, my judgment, that are have a good business mind. If you can't, or is really willing to rely on people in the staff who are really good at the business side of it, but who also live and breathe the mission of community health centers. Most of us will never pay full market salaries. I always tried to get our health centers to develop a policy that they would try and pay 90%, for example, or 85% of the market. But I knew I couldn't compete with the big medical centers or the private practices. And the difference of why you can get people is because of how they feel. Do they feel committed to the mission? Are they recognized? Are they appreciated? Is it acknowledged that it isn't always easy, but that people love that staff person for doing what they do and they love their job? So it's differed from 30 years, but I think some of it is important. So the other question is, where do you put your search? And how clear are you about what your search is going to be like? When I left the New York Health Center, I had brought on a chief operating officer who had great background in managed care, negotiating contracts, all those things, part of the community, been there for a long time. And I talked to my board chair and executive committee and said, you know, I am probably not going to stay here forever. And how do you feel about me grooming him? Not promising, but grooming. Oh, great. Absolutely, go for it. And then I gave my notice. And then it was, we're going to do a national search. And you can apply if you want. I ultimately was selected. But because it wasn't clear, part of that may have been my fault. Was he being groomed? Because that was an expectation, although I tried not to make that. Did the board feel they wanted to make sure he was the right person, but felt he was? Or did they have a lot of concerns about him? And I know in talking to him, that was very disconcerting. So the process and the clarity of the mission about how broad your search is going to be, and are you going to consider people currently employed, is real important. I know of another health center that there was somebody, a tremendous long-term director in your part of the world, but not Arizona, and clearly was grooming somebody. And that person just stepped in so seamlessly. And the executive director stepped back. But I talked to another person and they were selecting somebody, and this CEO said, and then I'm going to be around for a year to make sure the person works. It's like, no. How can that work when the ex-CEO is sitting right here and the new CEO is right here? And that's not a good idea. Some overlap, but certainly not a year. So do you extend your search beyond the usual NAC, PCA announcements, Indeed, the other kind of web-based? Do you go out to leaders in the communities that are diverse and let them know what you're looking for and some of the specifics? Do you seek assistance from people who represent diversity in your community? Because I think that's where you're going to start to get a variety of people applying for your position. One other thought, do you evaluate your CEO on an annual basis? I, in one center, would have to call my project officer and say, could you push that little button about wanting to be evaluated, that they need to evaluate me? Because I needed that feedback, and I certainly got it, I hope, but I recognize that a formal evaluation might get more feedback than I would get just on my own. And I think that's really critical. The board must keep a pulse on the health center to ensure that things are going well. Now, here's the challenge. You do not want a hostile work environment going on. You do not want an ineffective leader who is basically not present. But you also can't be micromanaging. So I have to tell you that this is a very delicate balance. But again, not that you should go to staff and say, well, do you like your CEO, or how's the CEO doing? But sometimes just picking up the vibrations, hearing what your patient tell you, my provider just seems really down lately. The morale has really dropped in the health center. That's a clue. We want to believe that all the people we hire are committed to our mission, are ethical, they have integrity, etc. But that's not the case. And true, it is probably rare, but I want to share with you a couple examples just so you know it can happen in community health centers. Hopefully it hasn't happened in yours. So the first one was actually when I was in Seattle, and we had just gotten healthcare for the homeless funding, and a person was being considered being hired, but one of the deals, if you would, that the community health centers had set was because a non-community health center was going to receive the funds, that they needed somebody with a healthcare background. And the person they wanted did not. And we stuck to our guns and they did not hire him. Months pass, I'm at a meeting with all the health centers in the county, and this new CEO of a health center is introduced. And I happened to have my COO at that meeting. And it was that person who was going to be hired for healthcare for the homeless. My COO took me aside a couple of days later and said, I have struggled with this, but I need you to know that he house sat for my father-in-law and wrote a check on my father-in-law's account without my father-in-law's permission. When confronted, he said, oh, I had friends over, they did it, I'll make it good, and he did. So then I had the information, I didn't know what to do with it. I struggled. I knew the board chair. I called the board chair. I said, you can do whatever you want with this. I will not spread this around. And I told her. And she implied I was racist and that my information was not appreciated. End of discussion. A year later, they had to bring in the police to, the word is escaping me, but basically follow him and follow the fact that he had indeed stolen money from the health center. He was out on parole, just so you get the kind of idea of what this person was like. He was out on parole, he jumped parole, and they caught him because he came back into Seattle and presented himself as a consultant for Boeing. And he had Boeing credit cards, so he stayed at really nice hotels and went to really nice restaurants, and he got caught. But that was an example of somebody that pulled the wool over the board's eyes, and then faced with some information, they were unwilling to look at that. One more example of that. No, this was not my experience, thank heavens. Many of you know Jackie Leifer. And I was one time at her place, and we were just talking about strange things that had happened on boards. And she said, did I ever tell you the story of Big Tuna? And I said, no, I'm sure I would remember that. There was a health center in Washington, D.C., which has now become a very expanded, high-performing health center, but it was kind of small and funky at the time. And this was a time, some of you will remember this, when you rarely ever competed for your grant. You just got it, and you told them you did good work, and everybody was happy. And all of a sudden, there was a notice of a competitive grant application for this particular site. And so the CEO called up NAC, who called up Jackie Leifer, the lawyer, and said, what the heck is going on? And she said, I'll investigate. So she and her firm started digging. And one day there was a knock on the door, and it was the FBI. And they said, you are messing with an ongoing complaint, search, and back off. And so they said, well, we will, if you'll let us know when you've completed your part, and then we can go in. Well, it turns out that Big Tuna was a mobster from St. Louis, and he was looking for diversification, and that health center would never make money, but it sat on really valuable land. And he thought he could take over the health center, run it into the ground, sell the land, and make money. And he's now in federal prison for tax evasion, which was, of course, why the feds were involved. The project officer turned out to be the brother of his henchman, and he supposedly is now doing massages in Kentucky. So a bizarre story, but it happened in a community health center that had a great CEO, was well run, and you never know what's going to happen. So the board is really needs to be alert. And it is my experience with coming in when the board has released the CEO is that they came in too late, that the clues were there, but I don't know why they waited for so long to take action. Was it wanting to hope it got better? Maybe not seeing the information, not hearing the information. Jackie and I worked up a policy when I worked with NAC to kind of address that, because as you know, the board is absolutely must stick to a chain of command in terms of complaints. And if a nurse has a complaint, it does not leap to the board as the first step. However, if the complaint is about the CEO, that's a much more delicate situation. So what we suggested the policy, but if you totally say we will never hear that, you're going to miss things, and sometimes some pretty drastic things. So one suggestion is have a policy that says when there is a complaint about the CEO, it will come to the board, and the only thing they will decide is whether it seems to have some validity. It is not just an unhappy staff person. And then it goes to a chosen attorney. And that attorney does the investigation. And that way, when the board does the investigation, what I have seen is boards split. Because some say, no, that CEO is the best thing that's ever happened. And the others say, that person needs to be removed. And now you have two problems. You've lost the effectiveness of the board and you've lost a CEO. So something to consider. One of the things that I think you really need to judge when you select a CEO is, are they strategic thinkers? Are they able to respond to new situations? And are they learners? And honestly, I think the learning comes first. There is a study's been done that show about 5% of adults are not learners. And what that means is they don't learn from experience, feedback, or introspection. They are a challenge to work with. I briefly worked for the health department, and before I ever got there, they called and said, you have to deal with this person, this manager. And I said, I'm not even hired yet. I'm hired, but I'm not there. So shortly after I sat down with her, because I knew that the goal was from others was to fire her, and I was willing to give her a chance. And we were just shortly into this discussion about things she needed to change when she said, well, this isn't how I'd handle this meeting. It was like, this is not about me. This is about you. And so if you have that experience when you're interviewing people, there's a way to find out, I think, with two really good questions to ask them. One is, think about your current job or your most recent job and a project you were involved in that went really well. And what did you learn about yourself? And then conversely, think about a project that didn't go very well. And what did you learn about yourself? People who are not learners find it impossible to answer that question. They will tell me all about the project in detail, even though I will ask that question in so many different ways. They will tell me who fell down on their part, not them. The learner will say, I learned I'm not very patient, and that got in the way of keeping people engaged. Or I learned I'm not as organized as I thought I was, and I need to improve my skills and make sure I have somebody there. Or I found out that sometimes humor really works if we had a great team, and this is what I brought to it. So make sure as you look at CEOs that they can be learners, because that means they're also probably going to be strategic thinkers. You know, they're always trying to learn something new, something different. I was meeting with a staff person yesterday who is our lab person, and he had read this great book. It was called The Patient Comes Second. I have to read this book, but it was talking about if you don't have staff feeling like they're really important, patient care will not be good. So patient comes second. Okay, so that's the strategic direction. Let's move on. Okay, so the old issues when we did strategic planning, and you all, I'm sure, I did this, folks. So this is me. You often took up old issues, okay? Facilities, capital needs, financial stability, succession planning. Those were the standbys that we often looked at. Interestingly enough, I would say succession planning didn't, as often as it should, come up as a part of a strategic issue. And succession planning not only for leadership, but succession planning for leadership of the board. Okay, so keep that in mind. So those are the old issues. They still remain. They still need to be addressed. Let's take a look at the next slide. So I think there is strategic planning. A little too often that becomes, it used to be until the feds would come out and actually check it. They would say you have to do a strategic plan every 3 years, for example. And as reviewers, we would come out and say, do you have a strategic plan? People would go to the bookcase, pull it out, blow the dust off and say, yep, there it is. Well, needless to say, a strategic plan needs to be alive. It needs to be used. And I suggest that at least on a quarterly basis, the board, one, has a calendar, and two, on that calendar, it is review progress on the strategic plan. And if progress is not being made, you have a discussion about it. Was this a goal that wasn't going to be able to be accomplished? Do we need to shift our tactics? Are we on track? So, it is important for a strategic plan and follow-up, but you also need strategic management. And that means that, your strategic plan may say, go X, but all of a sudden something happens and you need to do X -1. And the board and the CEO together need to be able to make that kind of shift. And particularly as we looked, obviously that's what happened with the pandemic. Many people had on their list was to increase the number of providers, to add operatories to a dental clinic, to start building a facility, and then things came to a halt. And so you need to do that strategic management to make that shift. And that requires strategic thinking. And strategic thinking to me is always thinking about the what ifs. And more, I like scenario planning for strategic planning, which is, what if this happened? Well, then what if we did this? Or if this happened, we did this. And it makes it a more alive process that is rooted in the strategic plan, but doesn't say locked into something which we just can't do anymore. So a couple questions you need to ask, but again, just remember, these are some of the questions you need to be asking yourself. We've talked about it before. We can go on to the next slide. Actually, go back. Sorry, I wasn't looking at my paper. So take a look at your strategic plan and ask yourself, does this currently serve the health center's needs? Okay, critical. Make sure you know how frequently you should be reviewing and updating that. And then how do you adjust your priorities? If you're not reviewing the strategic plan, then do you just adjust your priorities, never look back at the plan? And, at the end of the year, you go, wow, the plan took us this way and we went that way. You need, for example, health centers, I think for the most part, were very good about moving to telehealth. So we have a pandemic, our patients can't come in to see us for a while, or they may be limited in coming to us, they may be afraid to come into us. We need to move to telehealth. And I had my first telehealth visit with a new provider. And so I'm all set up for once my computer was working. And she came on and she had a mask on. And I wanted to say, you do know this is virtual, don't you? Well, you don't need a mask. I think she had just come from from an exam room. But those are some of the challenges. And I don't know for those of you who are rural in terms of telehealth, but I can tell you when you become remote, the health center in Alaska served 52 villages along a very long, big river. And usually internet was only at the school. And what we particularly needed to do was behavioral health by telehealth. Now you get into the whole issues of confidentiality, privacy, HIPAA. And so those kinds of things are things your staff works on, but you want to be assured that as you did or are going to explore more telehealth, that it's working for you and that, it preserves the right of the person who's on the other end. Obviously, one of the things I think that COVID brought was the need for more money. Thank heavens for federal funding. I think most, if not all, health centers got quite an infusion of additional funding. But one of the questions that has come up, and I, as a board, you need to be asking this question. You may not know the answer, but are we following the rules for expenditures? This came up with our board. Couldn't we do X? And I had to go back. I wasn't familiar with that funding. I hadn't, been working during that time. And the answer was no, you can't. I read that. So as new funds came in, especially those new funds, because they are fairly sizable for many health centers, just make sure you're following the rules. And then I noticed in the chat, some of you already primarily have virtual meetings. You may be in remote or rural areas, but you have virtual meetings. So think about what you're going to do in the future. I think we all know that there will be a new normal, but it's not going to be the old normal. And that may be that staff we have working at home part of the time may continue to work at home part of the time because it's efficient and productive. And you need to be sure it's efficient and productive, but I think many times it is. You need to think about, do we always need to meet in person for our board? Are there advantages to doing this remotely and through a Zoom or a meeting program? So at the moment, obviously, a lot of these questions are based on the pandemic, but they really can, what you needed to do for the pandemic and what questions you needed to ask and answer can really be a good base to prepare yourself for whatever comes next. And we don't know what's going to come next, but having just lived through my first tornado watch, everybody's very prepared for that at the health center. Sadly, evidently it was quite a lightning and thunderstorm, and I slept through it. So I guess I relaxed about this whole thing. One of the challenges, again, I think particularly in the pandemic has showed this, is we still need to balance our focus on the critical parts. Are we being fiscally responsible? We need to balance it on how are people working together? Are we seeing the patients we should serve? Are we productive? That may be a different kind of productivity. So you always have to have that balance between immediate and ongoing responsibilities and planning, and try not to bite off more than you can chew. I have worked with the health center, the most ambitious strategic planning. And it was like, I remember saying somewhere in the middle, are you sure? I mean, there was facilities and growth and all of this. And darn if they didn't do it, because it came back the next year and they'd accomplished it all. But they knew they could do it. But that meant they had to ask themselves a question because it was a very ambitious agenda. So that's another thing the board is responsible for. And you also have to know, you never know what's going to be thrown at you. And so again, nimble strategic thinking. Okay, now next slide. Ensure there's no conflict of interest. I'm going to read what a conflict is. So when an employee, officer, any member of his or her immediate family, his or her partner, has a financial or other interest in or tangible personal benefit from a considered contract or agreement. So the stipend was one example. There was a clear conflict of interest with the law. Interestingly enough, that health center had kind of a sordid past, but part of what happened is the CFO hired a new CIO and got involved with that individual and ultimately married him, and then contracted with his IT business in India. That is a significant conflict of interest. Besides, probably, you could argue not the best way to approach doing your IT. So you need a policy and standards. You need to communicate and document and have a process for managing. My experience in reviewing health centers is most of you are doing great. You have a conflict of interest statement that people, sign annually, and they're really good about signing it annually. Where I see it fall down sometimes is what actually happens when the conflict rears its ugly head in the middle of a board meeting. So a couple things have gone wrong, usually if that happens. The first is perhaps the person didn't put down that that was a conflict, but it became apparent that it was. Secondly, the CEO and or board chair knew it was a conflict of interest, but didn't address it in advance of the discussion that was going to happen. So let me give you an example. Health center needs to get a loan, a line of credit, and they're considering 3 banks. One of the bank officers sits on the board, clearly a conflict of interest for that individual to be involved in that discussion. In that particular instance, they let him stay in the room. They said he couldn't talk or participate in the discussion, but he could stay in the room. So you can imagine, the first problem is now he has access to information about the 2 other banks. Terrible conflict. Equally important, I don't know about you, but I'm not a very good poker player. It's very hard to sit there and hear another bank being discussed in glowing terms, and what you're thinking is, oh my gosh, don't they know they're poorly managed? And your face will show it. People, if that happens and you haven't dealt with it in advance of that board meeting, when that discussion is coming up, they must be recused from the room, okay? And one would like to think that never happens, but it does. One more thing, it's kind of the opposite of conflict of interest. It's making sure that certain interests are acknowledged. So ask your CEO, do we, in our contracts, do we give points for women-owned or minority-owned businesses? That's an example of, it's really not a conflict, but it is taking a group and saying, we believe they deserve preferential treatment. And there's nothing wrong with that as long as, you know, you're straightforward about it and it fits certain categories. So with that, let's turn to the next slide. Hopefully this is fairly obvious. Although I think that, remember, with all the COVID money, people may not be charged for testing or immunization. If they have insurance that will pay for the administration of it, you may charge the insurance company or the carrier, but if there is a copay, you may not charge the patient, okay? Even if they're not a patient of the health center. And in fact, as you know, with screening and vaccination, many of those people are not patients of the health center. We did a much broader community response. So just something to be, you know, charged with. It's useful, not only do you require to set the policy for the sliding fee schedule, but make sure it's actually being carried out. Ask the CEO. It's not your job to look at it in detail, but you do want to know, particularly if you implement a new sliding fee schedule and if you have increased your nominal fee. That's the fee for people under 100% of poverty. You can charge a flat rate. It is not as high as anything they pay on the sliding scale. And, you know, I can remember seeing a community health center in the community where I worked suddenly, you know, double their nominal fee, and all of a sudden we were seeing their patients. And they needed, that board needed to ask, what was the impact of that change in our sliding fee schedule? And is it serving as an obstacle for people getting care? So it's worth asking. And this is from me, who I was pretty hard-nosed, however, about if I would say this to our staff, if somebody comes in and they just come out of the bar and they have beer on their breath, or they have 2 packs of cigarettes in their purse, they have disposable income, they can pay a minimum fee, and I felt pretty strongly about that. However, now this is a administrative thing, but the board should think about it. We actually did have a process for excusing the fee, okay? And that was, it often is in the provider's the time the provider is with the patient, that it will come up. I'm struggling to find food for my family. I haven't come in for a month, even though I've been sick for a month, because I just don't think I can pay for it. We had a policy by which the provider could recommend that that be waived, that fee be waived, but I had to approve it. And the reason for that is our providers who are mission driven, bless them, are often bleeding hearts. And I know I just have everybody trying to be waived. So that was kind of the check and balance for that. By the way, make sure that when you're looking at a sliding fee and collections, that board members are treated the same as all other patients. An example, a board member came out of the exam room, owed a minimum fee or owed a fee, and said very quietly to the front desk, I'm a board member and I'm a little tight this month, so could you just waive it? And the front desk person was really not sure what to do, so she went back and talked to her supervisor and they waived it. So what do you think the next person in line asked? I want the deal he got. And he was told, oh no, our policy is you pay at the time of service. 2 lawsuits. I wish you could guess what they were. First one was more obvious. That was the second patient who charged discrimination, won his suit. The second lawsuit was the front desk person who felt that by following the orders of the supervisor, she did not get opportunities for promotion and was treated badly. And she won her suit. So as Jackie Leifer says, when a board member comes up to a front desk, they have this neon sign, whether they put it there or not, it says board member, board member. They needed to be treated as well as you treat every patient. But you shouldn't be treating them better because that means you're not treating the others as well as you should. So with that in mind, how did they get the copy about the early warning assessment? Can you remind me, Emily?
I'm sorry, what was that?
The early warning assessment, did they get a copy of that?
No, but I will put it in the chat right now, and we'll also send it out afterwards as well.
And don't send the one you have because I sent you the full bodied one. But let me tell you, I think sometimes monitoring the finances of a health center is one of the things that can scare people from serving on a board. I don't know if that's true more for, people who are patients of the health center or not, but there certainly is a group that doesn't feel adequate. And it is true that, the financial management of a health center is getting more and more complicated. So I'm just going to quickly go over this, but what you will see when you actually get the copy is some years ago, the health management associations defined what they considered financially distressed health centers. And what they were doing was looking at New York community health centers. Although they're called their comprehensive and diagnostic treatment centers, it was community health centers. There were a variety of questions, but I think 5 were the most critical. And again, you don't need to write this down, but just so you understand. One is, has your health center been unable to make payroll or pay benefits on time within the past year? Okay. The answer is yes. That's a warning sign. And that is also true of, has your health center been unable to meet contractual obligations? I had a health center, in the provider's contracts was that they would get incentive payments, and it was quarterly. That was bad enough because they were in significant financial trouble. What was even worse, some of you will appreciate this, it was based on gross revenue. We never collect gross revenue. There's always these, even Medicaid doesn't pay full 100%. So no wonder the agency was going under. But the previous interim CEO said, well, let's just not pay it. Well, contract is legal. It's a legal document and it binds you to pay. Say, now, we were able to negotiate with the providers and change that. But ask if, also ask about, are your taxes being paid? And that includes federal and state income taxes, unemployment taxes, all those requirements. Be sure you ask. Has there been a net loss in the last 3 years? Important to look at trends. You can have a blip one year. This year, 2020 may have been a blip because it took a while to get patients established again and coming in and bringing in revenue. But that should not be a continuation. You have less than 10 days cash on hand in the most recent year. You are just on the margin of terrible repercussions with that. A while back, I mean, it's been a number of years, Illinois, and I think Washington State did this too, they were having a budget crisis. So what did they do? They held back Medicaid payments. So they got to draw income on the money they held back, and the health centers didn't get it. And if I remember correctly, it was 8 months in Illinois before they got Medicaid payments. You have to ask yourself, do you have a line of credit or do you have cash on hand that can help you keep your doors open and pay your staff? And then there is a formula, it's called a current ratio, and it's a comparison of your current assets to your current liabilities. And current assets means you could cash it in within a period of time, and liabilities mean you have to pay it within about a year. And when I got to one health center, their current ratio was 65.65. What that meant was for every dollar of liability that could be called within that year, we had 65 cents. That was not a good status. And then finally, a good question to ask, are vendors refusing to deliver supplies without an advance cash payment? What that's telling you is they're not getting paid on time. And now they're, it's COD, cash on delivery, or even cash in advance. I was working in a financially distressed agency, and I discovered that right before the previous CEO left, he had come up with a contract for when the phone was on hold, that awful music that plays. And of course, we hadn't paid that bill because it was much more important to get dental supplies. And so I kept getting these nasty phone calls. And I finally said to him, okay, you have a choice. You can, and we'd asked them to discontinue the service, and they would not. I said, so you can continue to provide the service, and we're not going to pay you. Or you can stop the service, and we're not going to pay you. So that was a CEO, but that was a clue. The general question, are we having any problems with our vendors? Are they requiring cash in advance? Because again, that might be an indication of a financially distressed health center. So there's things about your current financial situation. You could look at hundreds of pieces of data, probably thousands. But again, a couple of those, real clear. One is, what's your total margin? Are you making a profit? Do you have a reserve at the end, or you always either right, almost to the dollar, or you lose money? Cash on hand, we already talked about. Accounts receivable, ask that question. Ideally, health centers should be paying within about 45 days. I actually had a board that said, could you slow it down, please? As we were at 30 days, because we had been in such disharmony with our vendors that when we got money, we really wanted to pay them off. And the board said, let's use that money a little bit. And then the other is accounts payable. You ideally want, somewhere around 30 to 45 days that you're paying on your accounts. I'm sorry, it was on accounts payable, but they wanted me to slow down paying. They didn't want to slow down receiving. So ideally, you receive what's owed you in about 45 days or less. Again, when I arrived at this health center, accounts payable, 265 days. And you understand why we were not welcome by any of our vendors. And this was critical because it was our dental supplies, our medical supplies, our non-children vaccinations. So those will be questions you want to ask. They're reasonable questions. They're limited questions. They're going to get you at the heart of if there's a problem. Obviously, you need to know if your fee schedule was reviewed. Requirement is every 3 years. But you must adjust the federal poverty level on which you base your sliding fee scale, because what the income level is for a family of four under 140% of poverty changes each year. So you must update that. You ask if you have access to a line of credit. You don't need a line of credit, but it's nice to know you have access in case something happens. And if you don't, you've tried and you don't, that also tells you about your financial status from an outside perspective. And then the last set of questions is take a look at your longevity of your senior leaders. How long have you had your CEO, your COO, your CFO, and your chief medical officer, maybe your chief dental officer? And are you having a real turnover in those positions? And if so, why? Because you're establishing policy, you're doing evaluation, but they're running the show. And if they're turning over very rapidly, you want to know why. Is this just a person who saw this as a stepping stone, or are there things going on that discourages people to stay at the health center? That was actually what alerted this particular health center, because they lost 2 very good physicians, a number of support staff, and finally the board said, what the heck is going on? Okay, I think we can go to the next one. It's your responsibility to select an independent auditor and accept the annual audit report. I think what's important to remember that accepting the annual audit report ideally means you meet with the senior auditor, okay? And typically what happens, well, typically from my experience, is you have a senior auditor in a firm that you work with, and then they send out all the junior auditors to actually do the audit. And so you want at some point to connect with that senior auditor who's going to be the most experienced and skilled in the area of auditing community health centers, because you do want that part because of just our unusual kind of financial situations and billing and reimbursement situation. Ideally, that person either should show up virtually or in person. You have time to ask questions. If there is a management letter, that is where they are telling you there are problems. It was the first time I ever heard the phrase going concern. We got a management letter. I hadn't been there very long at this health center. We have a going concern. So I go to the senior auditor and say, well, what does that mean? And he says, we have a concern you're not going to be going in a year. And boy, I already had a wake-up call, but that was the cold water in the face. So, it's useful to have that conversation and to be sure you understand as a board that if there were findings, what the corrective action is, and that the corrective action is actually implemented. That will be critical for you as a board. And remember, that gets sent to the feds. So as part of their desk review, they know how well you did on the audit, and if there was a management letter, and they will ask about, are you addressing the issues? Okay, next one. Oh, good. We're doing pretty well here on time. Assists in the development of the federal grant budget and the operating budget and approves both. When I came to this health center, they wrote their federal budget in the latter part of the year and approved it. This is the federal budget, grant budget, but their federal year starts in May. And so does their fiscal year. They match their fiscal year with their grant year. And they didn't do 2 separate budgets. So you had a budget developed at the end of the year that is now going to go into effect in May. And I don't know about all of you, but I don't have a crystal ball. So I don't know in the fall of the year what I might need to be worrying about and adjusting for. Have I lost staff? Is productivity down? Has the reimbursement changed? And there are things you can't put in the federal grant budget. So there are certain expenses that you can put in an operating budget, but not in a federal grant budget. They still do require you to not ask for any more money than they tell you to ask for, and should have a balanced budget that shows 0. And yet on an operating level, you should be building a reserve. There should be some kind of margin, a positive margin. So in my mind, and I don't know what you're all doing, but I think it's important to have two different budgets, and what you're really monitoring is the operating budget. The other, and that operating budget is going to be built on some critical elements that aren't really very complicated. The first is staffing. The second, and obviously all the details of staffing, of salaries, et cetera, and that, you know, FTE. Then of that staff, how productive are they going to be? How many visits or whatever you're measuring, widgets, are they going to produce? And then of all that produced, what is our payer mix? So is 50% of that we're measuring going to be Medicaid? Okay, then the next step is, what can we expect as our reimbursement from Medicaid? If 15% is private insurance, what do we expect? And it becomes really just a math, adding, dividing, multiplying, adding, subtracting, multiplying, and dividing. And voila, you hopefully have the answer, you know, your goals that you are going to set. Then it's up to administration and the senior leaders to make sure everybody in the organization knows that. Because I've come into places where the providers weren't very productive, but they honestly didn't know what they were supposed to be producing. And when, you know, we showed them the data and said, well, you seem to be seeing one patient an hour, and that's really not going to, I don't make money in the basement. There was a different, they got it and they understood it. So, and then let's take the next one. I think we're about ready to take a break. I think this speaks for itself. I do want to get us on a break. And I think the other thing is that as you look at the policies, again, just remember the world has changed. And for example, service site locations, who would have thought we would have been providing care in a parking lot with our patients in a car? Okay, that couldn't be anticipated. Who would know that we thought that to make sure we get people who are in hourly wages and are working long hours, that you need to be available at 9, 10 o'clock at night. My spouse got the first vaccine at 2:20 in the morning in the parking lot of the big Cardinal Stadium. Okay, that's when it was available. And voila, vaccinated. So those things, again, they're not set in stone. You really need to look at it in terms of what's going on in our world. Next slide. Should be coming to penguins any moment now. And Emily's thinking penguins. Are you having trouble moving the slide? There we go. And there are my penguins. Establishes general personnel policies. It is not the board's responsibility to make sure that the personnel file is up to date. It is not the responsibility of the board to know who's on corrective action if it is not putting you at a liability. What you do need to start thinking about is, do our policies address the issues of diversity, inclusion, equity, gender identity, and sexual orientation? And is it made real clear, just as much as we make clear that there is no smoking in the community health center, there is no drinking or use of substances in the community health center, it needs to be clear that these are values that we expect to see demonstrated in our community health center. We're not just giving lip service to this. And so I think the important question is, what will this look like if it's actually happening? If you walk into a health center and these issues are being addressed effectively, what will it look like? interesting topic for your board. Let's get up and move along with the penguins. And we will come back. Can we make it 7 minutes after 3? Does that work?
Sounds good.
Okay, thanks, Emily. All right, everybody. See you in 10 minutes. I think we have about a minute left before we regroup. Okay, why don't we see if we have regrouped? We appear to have lost a few people, but not many. I know who you are, and I will follow up with you. So Emily, we ready to go?
We should put enforcer under your title also.
Hey, I was a high school vice principal. I know how to be tough. Actually, I was a high school vice principal in a Catholic girls' school, and I wasn't Catholic, so that was an interesting challenge. And I really felt like as a vice principal, I had to be fair. I learned that early on, but also consistent. And I would tell the teachers, listen, don't come to me with they're wearing their skirt too short or their socks don't match. If I deal with that, they're not going to listen to me when they really do something rather outrageous. So one day I was coming back from the post office at lunch and I was walking up these steps that were kind of hidden by bushes, but they passed between the church and the school. And here were 3 of the students smoking cigarettes. And I said in my sternest voice, I will see you in my office in 5 minutes. So 5 minutes passed and here come these 3 heads down girls. And I said, you're not in trouble for smoking. And of course, they were astounded. I said, you're in trouble for being so stupid. Anybody could have walked up those steps and seen you, and you would have been in more trouble than you are right now. So anyway, that's how I have used many of the skills I learned as a vice principal, CEO.
Right.
That, and I think being a mother really keeps you humble for those of you who have children.
Yeah.
So is Jeff on? Raise your hand or come alive. See, I'm tracking you down. What about Kimberly Williams? How did I just pick the people who are missing? This is amazing. Nope. Hi, Kimberly. Okay, she's there. Hi. Oh, let's pick on one more person. Laura Mendoza. Oh, no, I asked about Laura. You were here. How about Thomas McCabe? Are you here? So I have, oh, Laura's here. I haven't heard from Thomas. I don't think I heard from Jeff, so watch out. Remember, I lived part of my time in Arizona. Okay, let's go to the next slide. One of the things you're required by the board is to evaluate the performance of the health center. And the critical issue is, but how do I do that? So there's a process and it requires information. I'm just going to list, we've already talked about most of this, financial reports, not 140 pages, but succinct financial reports that tell you how you're doing compared to what you said you were doing. Where was there a significant difference? Why, and what are you doing to correct that? The audit. You should know about patient satisfaction. I think doing it once a year is not terribly successful. So you need to think about how are we going to find out about patient satisfaction? And are we using our consumer board members to help us in that? Staff satisfaction, that is a really good one to ask. Your quality improvement, quality assurance reports should be reported to the board. Measurements against the strategic plan, we've already talked about that. And then ideally that's presented in a dashboard. So you get this succinct, chart, for lack of a better word, that they often call a dashboard, that tells you on these key financial elements, this is where we are, this is where we said we'd be, etc. Graphs, I think, really help. Trends are important. So, a single blip of something, maybe nothing to worry about. Blip continues, you need to worry about it. And then the feds provide you information. Every year, February 15th, for your new board members, every community health center is required to submit a uniform data system report called the UDS. And it has a great deal of information. So there's demographic information about the patients, their gender, their identity, their poverty level, their age, pretty robust, asking whether or not they're a vet. Are they homeless? Secondly is a provider and staffing profile. How many primary care physicians do you have? What percentage of time do they work? That kind of information. Then you go to, given your patients and your providers, how well are you doing in the area of quality? And there's all sorts of quality indicators that they measure, including looking at what percentage of children under a certain age do you have immunized against what is the goal of having them immunized? What percent of your diabetic patients are 7 or under in their blood measurement? Because that's a goal. And so that's another piece. Second major piece of feedback, but it only happens about every 3 years. It happens in the middle of your grant period. So, for example, we're due for one in 2022. No, we're due for one this year in 21, because in 22 is when we'll actually have our competitive grant. And that operational site visit will involve you. If you haven't already been involved in one, don't panic. It's usually not painful, but it is very informative. And there are usually 3 reviewers, a administrative governance, that's usually what I do when I go out, a financial and a clinical person. And they're looking at, are you in compliance with the rules and regulations of the federal funding? It used to be that there were also these, we think you should, and it would be nice if, and some reviewers took that to the extreme. I always say to the board, if you wonder if that's really something that is a requirement or a regulation, ask. For the most part, it almost always is nowadays. But I remember just having to challenge a reviewer saying, let me see it in writing that it's required to be this way. So you get all that information. And I remember, this is the second time I've been to this agency, and haven't had great luck on CEOs. And I was sitting in a quality assurance meeting, and there was an hour of data, and it was great. I mean, it was expansive data, it was interesting data. But I went up afterwards to the person who presented, and I said, there's a critical question that didn't get answered. So what? What does it tell you? And that's really the critical role the board plays. Make sure you have the data, but then ask yourself, so what? Do we have outliers? Are we not on goal in terms of our budget, our spending, and our revenue, and our productivity? And by the way, that's not individual productivity, but it might be dental productivity and family practice productivity. Many health centers get into trouble when the data is right before them, but they fail to ask, so what are you going, why is this there, and what are you going to do about it? And you as a board should expect a response, and it may actually require coming back to the board with a corrective action plan. If you are, let's say your revenue is 15% below what you projected, that's significant. You're going to want to know from your CEO who works with the CFO, why did that happen? And what are we going to do about it? Okay, we're going to cut expenses. We're going to go after additional revenue, etc. Next slide, please. I wish I could see you raise your hand. I would like to know how many, this is a requirement of the board, okay? Ensures compliance with applicable federal, state, and local laws and regulations. I'd like to know how many of you know what are the applicable federal, state, local laws and regulations. I don't know them, but you have to make sure we're complying with them. So what do you do about that? You know, that's really the critical question, because I doubt there's anybody on the board. There hopefully is at least one person on the staff, two, who knows the critical ones. And then you have to have a system to make sure that you are following it, okay? So, for example, larger health centers may have a corporate compliance officer, and the really big health centers, we actually have a compliance officer, but really big centers may often have an attorney filling that position, not required. The position isn't required, neither is it if you have the position that an attorney, but it does mean there is a point person who's keeping his or her fingers on the applicable, etc., and working with staff to make sure that you are following those critical requirements. There should ideally be a corporate compliance committee. And here I'm going to put in an ad. Nobody paid me. Nobody asked me to do this. But the firm of, oh, nothing like blanking, Felsman, Tucker, Leifer, and Fidel. That is the group that Jackie Leifer belongs to. And they have quite an excellent training program on corporate compliance and a toolkit. I have lost track of how current those are being offered. It certainly hasn't been offered recently. But if you can afford it, and if they're still doing it, I think it's money well invested, because they really know health centers, but they also really know the law. By the way, the the Quality Assurance Quality Improvement Committee looks beyond clinical care. Okay, they're really looking at what are the critical things that you should be doing right, and where are you liable or where are your risks? And let me give you an example. Now, I don't know if this is true in every state, but it was true in Washington and New York. It used to be that when Medicaid did an audit, they called you up and said they were going to be on site on certain dates. And would you please pull X number of charts? So let's say 100 charts and have them ready for us. And these are charts of Medicaid patients that you've billed for services provided to them. Now, health center people are pretty darn smart, and they are not going to pull 100 charts that show non-compliance. Why would you do that? Well, Medicaid got smart, and now in those two states at least, and I certainly know in New York when I left New York, they arrive unannounced. They have a list of the charts you pull at that point in time, and they review them. And what they're looking at is just the documentation warrant what you charge, even though you're getting paid, a visit rate perhaps. Does it warrant what you charged and said you did? And if it doesn't, then, and let's say 10% of those 100 charts that they asked you to pull, that they pulled, don't, they will assume that 10% of all the billing you did to Medicaid was not documented and therefore should not have been paid, and you will have to pay them back. And there might be a fine with that. So that's an example of a QI committee develops a priorities plan, looking at starting with where are we most at risk. They need to have metrics. How are we going to measure this? They need to gather data, implement changes, gather data again, and report out. So one of the last slides, and this is the responsibilities in the new world. Now, you know that one of the roles the health center plays is a key link with the community. And I've given, examples of this. What I often think we miss as an opportunity is that we can provide informal marketing. If you ask people, how did you hear about the health center? Their more frequent answer is, somebody asked, did anyone else's screen freeze or cut out? I don't know. So far, I'm good. They will say, family member, my aunt, my friend, I heard about it, when I was playing cards. And so, if you're out there talking about, well, I go there and it is an amazing place, or I serve on their board. And let me tell you, they are doing wonderful work. They're providing quality of care and they're doing it efficiently. I think that is a really important role that the board can play. It's also a role you can play, which is dispel misinformation and gossip. And I was going to say the smaller the community, the more that's likely to happen. But the truth is that even in a large urban area, there's neighborhoods and communities within that large urban area. And boy, can gossip and misinformation spread like wildfire. And sometimes it's helped by the local paper, especially if you're in a small community. I've now had to deal twice with the local paper here who wants the details of the removal of the CEO and will not take no for an answer. It's like, I'm sorry, I can't give that to you. That is not information that is to be shared. And one time the last time I was here, they got so upset, they would no longer take our ads. Fortunately, the hospital strong-armed them and now they are taking our ads again, but that's an example of managing gossip and misinformation within a community. You can also serve, and we've talked about this before, we gave the example of the perinatal programs, is serve as a voice of the community, giving staff another side of one picture of care. So in times of the pandemic, one of the things that's really has been recommended is that board members, and really all board members, serve as ambassadors for the health center's COVID care. And this is really critical. So first is talk to the community. Now, other kind of marketing is going on, but talk among your friends and your family and your social groups, if you're being social, about the services that the community health center is providing. By the way, you can drive up and you can get tested. You'll get results in X amount of time. Or we're doing vaccinations and we've now opened it up to everybody 16 and over, for example. And they're really good. You know, you're going to get good care. It's also a time to really talk about the vaccine and talk about where they can get accurate information. So I live in a gated community when I live in Arizona. And the people below us, we have a condo. I was talking to them because the woman works for hospice. And I said, so have you gotten vaccinated yet? By then I had. She said, no, I'm not going to. I said, really? I said, they don't require us? No. I said, well, why aren't you? She said, because it will change your DNA. Well, you know, part of me said, this is the most irrational thought. Hope I don't offend any of you. But that's not what science shows. A staff person recently who has not been vaccinated yet said, you know, it took years to develop the flu vaccine, and it only took them months to develop this, and I don't trust it. But I was able to say to her, and this is what you could say if these things come up, yes, but this whole knowledge base of vaccines started as they worked on things like flu. They were much further along. They just had to adapt what they knew to this new virus. So I can't emphasize enough that respect people's right to make their own decision. We need to do that. But at the same time, this is my personal opinion, we need to talk about their community responsibility. And the fewer people who get immunized, vaccinated rather, will take us longer to get out of this pandemic and back to living differently, if not normally. So you are on the line of being able to dispel misinformation, give good information, say, you know, if you have other questions, we've got great providers and other people who can answer those questions. If you would like to just go see what we're doing, feel free to do that. And then you step back and say, I hope you make the decision that is right for you. Okay, demands on the board. Next slide. So effectiveness, making a difference, efficiency, making a good use of all resources, and accountability. And we've really talked about all of that. You will have measurements that you have set in place. You will have your quality measures that will tell you whether you're making a difference. You'll have efficiency measures that show you how well you're using your money, effort, and time. And remember, you have to be in compliance with those rules, et cetera, et cetera. So on one hand, you're requiring accountability. You make sure you're operating by high standards. There was a report that we developed at NAC. And in fact, my new chief medical officer just came across it. And it's called Going from Good to Great. And it was done, even though it's dated in the sense of how long it was developed, we hired a consultant who did 25 individual interviews and focus groups, read original literature about community health centers, and developed kind of the qualities of a high-performing health center, a great health center. And I always think that's useful to use, like when you're doing your strategic planning, because it sets a vision of where we could be, or it may tell you, wow, we're on, you know, we hit the nail on the head, we're doing it. Okay, next one. Okay. Here's the problems that come with many meetings and why you may find people disengaged, or conversely, you feel like, gosh, I'm not sure about these decisions. So one is lack of preparation, goes back to expectations. You're expected to read the materials in advance. Staff, that means you're expected to produce them in advance. And producing financial reports the day before the board meeting is not very effective. My personal opinion. So one, We guarantee that you will have the information you need in a timely way, and then we expect you to read it and prepare for that board meeting. Not focused. Here you go with, there's some wonderful training for board chairs, and a board chair needs to lead a group of people. And as you know, sometimes that's like the old proverbial herding cats. They're headed in different directions. You need to bring them back together and make sure that the critical issues are discussed and the decisions are wise. I had a board that when things broke down and they couldn't come to agreement, they moved to vote. I called the motion and I was like, no. One time of these, at the time, 7 independent centers that were working with us, one of them was a bit of a renegade. And so they were discussing what to do because the federal funding came through our organization to them. And they were stuck. Somebody called the motion, they got removed from the group and federal funding in an instant. And then we had to backpedal. I said, that's not a good way to make a decision. Only a few people participating. Again, the board chair, and if you have another really good board member who's a good facilitator, communicator, call on that individual, but make sure you give people an opportunity to participate. And one of the things I've learned over time is that people can make decisions and gel information in different ways. So there was a study done that looked at different ethnic groups and how quickly they interrupted somebody's sentence, okay? And it was very telling. I don't even know how accurate it is. I'm not going to share who did what, but what it said to me is people, and sometimes it's cultural, will respond in different ways. So sometimes what you need to do is get in the heat of the discussion and then say, let's take a 5-minute timeout. Think about what we've just discussed. If you have questions, you can do that informally now. If you don't want to ask them. And then we're going to come back and we're going to complete this discussion. Sometimes I'm sure you've had this happen. The discussion goes round and round and round, and you don't realize you've already made a decision. But one person keeps saying, yes, but, yes, but. An effective way of dealing with that is do a straw poll. Where are you right? We're going to take a poll right now on this decision to do X. Are you 1, can't support it at all? 2, don't think it's the best idea in the world, but will support it. 3, fully support it. And then for those ones, what is it going to take to move you to a 2? What's getting in the way? Because that will be very telling. And lots of times it can be dealt with. Lots of times it's a lack of information, misinterpretation, etc. And then pressed for time, but still feeling the meetings should be an S on there, are too long, or they're just plain boring. And what can I do with boring? So next slide. So how does the board accomplish all this? Well, one is effective committee work, and important to understand what's done in the committee and the authority of the committees and what's done by the board. The committees recommend. The committees do not approve policies, approve the financial reporting, approve the audit. The committee condenses the information in a way that all board members can understand it, but there's enough information to make very thoughtful decisions about it. And that needs to be very clear. This is your role. I've worked with boards that have an executive committee, but they never meet. And I say to them, but you're kind of the managers of the board. So how does that work? Some have committees and then they duplicate everything that is done at the committee at the board meeting. Well, first of all, the committee people get, kind of frustrated, like, heavens, why did we go through all that work? And the board may be a little overwhelmed with all the information. So get clear about your expectations. Next slide. So we talked about that. Having an effective reporting system. I think it is really important to occasionally ask your board, are you getting enough information? Is it too much? Is it in useful formats? And really listen to them. And what's important, I think, in any situation is to listen for themes. If one person says, this is just way too much information and I don't understand it, you'll want to talk to that individual, but that may not be a reason why you change how you're doing things or what you're providing. But if you see a group of people are saying the same things, then you need to listen to that and consider some changes. Next slide. Some even more tips. Now, I know that money is tight and not every health center can do this. But even if you just bring cheese and crackers sometimes, it improves attendance, especially if you're having a meeting at 6 o'clock at night, which a number of boards do, and they haven't gone home for dinner and they're hungry and then they're cranky. So if you can, provide some modest amount of food and drink. Make sure you have prepared members. You have a very clear and focused agenda that ideally is developed in advance with the CEO working with the board chair. The CEO's role is to say, these are the critical issues that the board needs to grapple with at this meeting. Here's the background behind that. And then an agenda is developed, usually by staff, but approved by the chair and then presented to the board. And it should be clear, and we'll talk a little bit about the consent agenda, where you just kind of combine a variety of things that are just literally routine, minutes, those kinds of things. And if there's no objection, you approve them as a whole. So you can move on to the meaty issues that you need to discuss and have adequate time, and your board meetings don't go more than 2 hours. It's very useful to have written reports from the committees with the requested action of the board noted. And then it's useful to, I think, as a reviewer, keep a log of the motions and decisions that were made as a attachment to the board minutes. And I say this because, for example, I will need to see that the board approved the federal grant budget, okay? Now I can wade through the board meetings that they've gotten me and I will find it, or I can look down this list and then at this board meeting, this was approved, motion and approved, it, you know, and it's so clear. So I think it helps keep the board clear about what you've decided on. And it certainly helps anybody who's coming in and doing a review. And even though we're not supposed to consider that, I can't help but believe the ease at which you can, you know, do efficient review might influence how you evaluate. Not in terms of compliance, but just in how you approach it. So next slide. We talked about the consent event agenda. I should have asked a question of how many use a consent agenda, but I didn't think about that at the time. Again, this does not require discussion before a vote. It's standard, non-controversial, self-explanatory, and you combine it, you move to approve the consent agenda, it gets approved, you move on. The other thing is, unless everything is falling apart and needs immediate attention, pace yourself in terms of what you discuss at board meetings. So if you have a critical loss of revenue and you're worried about succession planning, and if you can, take a bite off at each board meeting or 1 or 2 issues. But if you try and discuss everything at every meeting, it's like we talk with providers. Our patients often will come in with 10 issues, and I know it's hard, and you know they might not come back, but you're not very effective if you try and address all 10. So, you know, where's our priority, and then know where you're heading next. Okay, next. If you are stuck in the discussion, what do you do? Now, this is in homage to my spouse, who always says, there are only 3 people who are stuck, and they are at the bottom of Hoover Dam. Apparently that is true. I've not checked it out, but people do get stuck. And that goes back to get a pulse, find out who is stuck and why. I'll use an example. It was not actually a board example. It was a management example, but it could have just as well been a board. So we were debating a really critical issue, and I took a pulse. And it was, on a scale of 1 to 3, just like I gave you before. And one of our clinic managers gave it a 1. And clearly said, I'm not prepared to support this. Why is that? Let's find out. What is it going to take you to move from a 1 to a 2, where at least you may not think it's the best idea in the world, but you're willing to support it? Well, it turns out the medical director wasn't able to attend that meeting, and he basically said to her, make sure my voice is heard. And she was afraid she hadn't. So we said, what does he want us to know? She told us, we listened. She became a 3. And that can happen at the board level also, that you can move people if you find out what's sticking them. Sometimes it's lack of knowledge. Sometimes there are a few where they just like to be stuck, but that comes up in how long you keep people on the board. Have it be a give and take, not show and tell. Nobody, and here I am, I've been talking for 3 hours and 40 minutes, and you're probably saying, yeah. But find different mechanisms why you get people to share from their area of expertise. And then sometimes you can ask them to wear a different hat. So you can say to somebody who's like, here's an example. I think our minimum fee should be raised at least 20%. My gosh, we're struggling and it should be raised 20%. Well, that person may have a very valid reason, revenue is coming. So, okay, so would you just for a moment step into this patient's shoes? Single mom, working an hourly job, 2 kids, doing the best she can to support them and give them more in life than she has. But just every penny is accounted for. One son has asthma, needs to be controlled, has been told by her work, for example, that if she's out one more time dealing with her kid who's having an asthma attack at school, she's going to get fired. Now, what do you say? And you get that person to think about that. There may be a compromise. Okay, you're right. I would like to see it raised $3 at least. But if, on the other hand, that person who is, the wonderful bleeding heart liberals says, no raise whatsoever, then you need to give them that other side of the coin. Well, one of our patients, they do have some disposable income. And I think we try to show them respect and honor them. But they also need to be part of the solution. And they need to understand that we're not free and we provide quality of services. And you would not go to a grocery store and say, I just bought cigarettes and a beer and I can't afford my bread, give it to me. So getting people to understand the different elements, I think, can really help. All right, let's see. And I already said to, please don't go from stuck to let's vote. One of the things I really like to do, and you may not do it every board meeting, but I think you should do it frequently enough, is on a scale of 1 to 5, how satisfied were you with this meeting? That can be true for this training. So I always say a 1 is, I really wish I had spent my time at the local coffee shop. 5 is, this was great. I was engaged. It was a good meeting. I'm so glad I was here. 4 leans towards 5, 2 leans towards 1, and 3 is in the middle. And then ask what influenced your score and what would you like to be different to move you from a 4 or 5 if you rated the meeting lower. And I used to teach a management class at the University of Washington. And one day, it was an evening class, it was adults, it was 3 hours long. And as soon as I walked in the room, I knew it was just flat. There was no energy in that room. So I did a poll. And I said, on a 1 to 3 scale, where are you? And what would it take? By the end of the 3 hours, they were engaged. but I needed to hear what was holding them back, and they needed to just be able to say it. By just saying it sometimes changes your attitude, your voice, whatever. I do think it's important if you're using this method for a decision and you're trying to see where people are at. What I tell people is, okay, a 3 means I totally support this. I'm going to walk out if you're unsupported. 2 means I don't think it's the best idea, but I will walk out of here and I will support it. 1 means we better keep talking until you reach a point where you can support it, or we need to decide how you're going to manage that lack of support. Because what you don't want at a staff level, at a board level, for people to go, yeah, okay, whatever. And they walk out and they immediately badmouth the decision. They put up obstacles. You need to make sure that you've got, if not consensus, certainly agreement on what you're going to support. And ideally you say, and we are going to reevaluate in 3 months or 6 months to make sure this was a good decision. But in the meantime, we expect you to support it. Next slide. So are there any questions? I guess they can do that through the chat, right?
Yes, so we do have one question already that came up. Carolyn was asking about the toolkit that prepares the compliance committee to know about the laws.
I will, I'm going to make a note. So there's 3 things I've agreed on so far. One is to send via Emily and others that kind of how to evaluate the financial status. I will send, I think we called it a value statement, but that statement about what the board believed in. And I will get information about whether that compliance training tool, et cetera, is still available and how to get handle on that. I will do that.
Thank you.
Sure.
And then if anyone else has questions, feel free to put them in the chat, or you can unmute yourself, I think, at this point and just go ahead and ask.
See, at this point in a training, if there's no questions, I bore you with the story and then questions come about. So I want you to know I have a dog, and my dog is a puppy. She's now 4, loved tissues, Kleenex, and she would bury him in her dog bed. So being a very smart dog owner, I moved everything up so she couldn't get at it. And I kept finding tissues in her dog bed. So one day I'm sitting at a table that is near a bar stool where I loop my purse. And I watch her go over and unzip my purse and get my tissue and bury it in her dog bed. She then progressed to sports bags. And then I was doing some work in a place that had excellent chocolates. And she learned how to open a suitcase. So part of why I stay away from home sometimes is she's smarter than I am and I need a break. I'm a very smart dog. Now, if that didn't inspire you to raise more questions. Let's go to the last slide. I want to thank all those I worked with the Alliance. What they didn't share with you is when I was at NAC, the IT people threatened to exercise my room because there were tech problems that never happened anywhere else. In fact, at one point I was doing some word processing and it started typing from the right to the left, and every letter was turned backwards. And I told that story here, and the IT people looked at me like, you're nuts. And then the next day I made, like a 10 copy document, copied 10 documents, and every other page looked like it was in Hebrew. So I said, see, I do this. And so they have had to struggle with me of Zoom working, not working, I'm muted, I'm not muted, I can't get hooked up, and extremely patient. And you really have an amazing staff at the Alliance. So kudos to them. Board Source is a good source for information about how to effective boards. NAC has somebody dedicated to working on governance issues and how to be effective board members. And then really, I learn something every time I go out and work with the health center, whether it's with the board or the staff or the community. And I have learned so much from all of you and people like you, and you continue to inspire me, which is why, as my oldest son says, you have the strangest idea about retirement, because I'm still learning and still loving what we do. So thank you.
Thank you, Julie, and that's why we love to have you with us. If we don't see any more questions in the chat before I'm finished, I really just wanted to thank you again for being with us, for sharing your experience and your insight and the tidbits that really make it interesting. Our health center board members already know that there's our very full plates with a lot of responsibilities, and I'm sure that you've given them even more food for thought and opportunities for discussion. So that's wonderful. To our board members and health center leadership and staff, if there's any additional training that we can provide to follow up on anything that was discussed today, please let us know. We welcome the opportunity. For one example, we have provided training in the past around sexual orientation and gender identity to health center staff so that they are best prepared to work with all patients, that they understand terminology, and most importantly, that they had a comfort level themselves that then translates to patients that feel comfortable and welcome to your health centers and have access to the appropriate and the best care. So to support your efforts as a board in creating inclusive and welcoming health centers, we can do something similar with that for our board members as well. So that's just one example. But again, please follow up with us. Let us know if there's anything you'd like additional information or additional training on. We ask again that you please provide your feedback, your satisfaction with the training, of course, and then your feedback on additional topics or anything that you're interested in future trainings. Are there any more questions in the chat that came up while I was talking?
I saw a comment about wanting some training in the area of Robert's Rules of Order, and I'm the last person to ever do that, but there's some great cheat sheets out there. If you go online, they're usually laminated and they're no more than like a legal pad, and they really condense the things most critical to running an effective community health center board meeting. You are not the board of Microsoft, but you still need to follow the basics. And I found that really useful because I can't remember them.
Well, and I can share, thank you for that question and your response, Julie. I do have some of those cheat sheets that I'm going to share. So we will because we've had requests for them in the past. So we'll include that on the materials that we're sharing out to all attendees.
Great.
And Vita, I'm not sure, and I apologize for not being sure. Is the Survey Monkey link that you put in the chat the one that everybody should use to provide feedback?
Yes, so I provided the SurveyMonkey link, which is the official evaluation for this training. And I also see that there was a question about the recording. I do have a recording, and as soon as I finish editing this video, I will send it to all of the attendees of this training.
Thank you for somebody already completing. Kimberly, for completing the survey. We appreciate it. Okay. Julie, any final thoughts? Anybody, anything they'd like to share? Emily and Vita, again, thank you for working with Julie so closely and putting this together and keeping this as engaging as possible at a time when everybody is experiencing some video call and conference and meeting fatigue. So thank you all for sticking with us. And hopefully we will be back to whatever normal is soon and be able to see you again face to face, because I miss that.
Me too.
Okay.